Welcome, everyone, to the Disaster Response Collaborative focus area session on pediatric surge capacity and capability. This is our June session. So June and July, we will meet with focus area groups, and then we will go back to our full collaborative session in August. The Pediatric Pandemic Network is supported in part by the Health Resources and Services Administration of the United States Department of Health and Human Services. We do have a cooperative agreement with them that you can see here. And just keep in mind that the content presented here is that of the authors and does not necessarily represent the official views of, nor an endorsement by, HRSA, HHS, or the U.S. government. For those of you seeking CEs, continuing education, this slide will tell you a little bit about that. We are offering CEs for physicians, nurses, and social work. At the end of today's session, you will have a slide that will give you a code that you can take to the website or to call in, to text, and get that CE credit. So thank you for joining us. We hope that you are enjoying DRC and getting a lot out of it. We'll go through a little bit about where you should be in the process, but hopefully you are getting your tabletop exercises and your PDPAC. But we are very, very happy to have you with us today. So thank you for joining. The session is being recorded. I always like to stop and check and make sure. And the recording and slides will be posted to the website later this week. So if you have any questions, feel free to post those in the chat. We will also have time after our speakers today to hear from your questions and have them answer aloud. Again, MOC Part 4 credit for physicians as well as CE and for physicians, nurses, and social workers. We need to update this slide. EMTs, we are not able to give CEs for at this time. Again, the Pediatric Disaster Preparedness Self-Assessment for Children's Hospitals. Hopefully you have registered for that. Many of you have, we've seen that have submitted, so thank you. Hopefully many of you are working on that. We are going to keep that open. So if you have not had time to register or not have time to complete that, you still have time. So we'll have more information later on in the session, but again, we are keeping the PDPAC open. That is the environmental scan for DRC, and we want to hear from you. We want you to be able to get the best information so that later on in the year, when we start to look at those drills, you know really what you want to improve on. Here's our agenda for today. And at this point, I will hand it over to Dr. Hussein, who will introduce you to that. Thank you.
Hi, everybody. Thank you for joining us today. I know the weather's getting warm out and a lot of you are probably have your mind elsewhere, but this is such an important topic and really one of my favorite topics in disaster preparedness. Hospital incident command systems, I am a huge advocate of as such an amazing system for managing not only disasters, but many other things as well. We've got some great speakers for you today that are going to walk you through some basics just to kind of get everybody leveled on what incident command systems can do, and then giving you a great perspective of real life experience in using incident command systems. And then we'll go into our breakout sessions, which I know that all of you really love hearing from your colleagues. So excited about today's session. Next slide. So after the session, won't read the slide to you, but we think that you're going to have a good background on incident command, and then be able to also develop your own incident command to have very specific pediatric positions and build it so that it has pediatric focus. Next slide. Without further ado, I am going to let our two speakers introduce themselves. We have David McCarthy and Dr. Brent Kasny, and welcome them today.
All right, I'm David McCarthy. I've been working in healthcare emergency management for about 20 years, started with the hospital system, and the last 12 of those as a contract consultant working with hospitals and healthcare systems. I also serve as the Arizona coordinator for the Western Regional Alliance for Pediatric Emergency Management and as the drills and exercise domain manager for PPN, and along with my associate Chris, which some of you may have met or hear from more frequently, we are guiding the virtual tabletop exercise series that's been offered through the DRC. Over to Dr. Kasny.
Hey everybody, my name is Brent Kasny. I'm a pediatric emergency medicine doc at Texas Children's Hospital. I'm also the medical director of emergency management for the hospital system down here in Texas. And in that capacity is really what I'm going to be speaking about with you today. But I also serve as the principal investigator for the Gulf 7 Pediatric Disaster Network, one of the 3 pediatric disaster care centers of excellence, and the co-lead of the disaster management domain for the Pediatric Pandemic Network.
Next slide, please. So I'm not here to go into depth. I was asked to give just a brief overview. Some of you out there are probably well versed in the hospital incident command system, and some of you it maybe is just a brief exposure or not at all. So I'm going to give you that quick overview in about, hopefully not more than about 10 minutes, and turn it over to Dr. Kasny. Next slide, please. So the key thing about the hospital incident command is that it's flexible, modular, and scalable. When the current, if you ever get a chance to look at the full chart, there's some 75 positions. And I always like to remind everybody, the goal is not to fill the boxes, but only fill and assign those roles that are necessary for your response in a disaster or emergency, or even a planned activity. So some of the other key features: common terminology, modular organization, on down through their manageable span of control, unity of command, resource management. And the key thing is that it become documented for your own purposes and use through the incident action planning process. Next slide, please. So I like to refer to these as the big boxes at the top. When you look at the full chart, there's a bunch of other boxes that report under there. And just simply to highlight those things, that the hospital incident command system is what's referred to as NIMS compliant. And the key thing there is it's like other incident command systems, starting with the Forest Service to fire service to law enforcement, and keyed into our national response. And the bottom line is there, if you were to look at their incident command charts, you would see the same big boxes at the top. Those that report, particularly under operations and below, will vary based on the mission at hand and the agency or jurisdiction that's responding. But so keying in on that, next slide, please. That there's some key elements there. There's the command staff, starting with the incident commander. There's always an incident commander. It's the first and position that must always be filled in our incident command structure. Then we have several officers that report to that incident commander. Some of those may sound familiar, like the public information officer, who's going to deal with external but also internal communications about the incident. The liaison officer, who's going to communicate with outside agencies or organizations that may provide resources in our response. Our safety officer, whose key thing is to watch out for everybody in the operation and the response. And they do have a key thing in terms of their responses. They're responding or looking for safety hazards, they are the only one besides the incident commander that can actually call a timeout if there's a concern from a hazardous standpoint. And a newer box that was added to the top was the medical technical specialist. And I'm going to talk a little bit more about in detail in regards to that. But essentially, it's a consultant role in terms of the response to the incident commander or incident command. Next slide, please. So then we have the 4 boxes across the bottom, the general staff. The operations, they're assigned as section chiefs. The operations section is simply the doers. Whatever the doing is, it falls under operations. The actual work or tactical response in terms of the response is conducted by the operations section. That could be certainly medical care falls under that, but also it could be just, the facility or infrastructure responding to a flood in the basement. And so whatever the doing is, that's where it happens. Planning is just that. The planning section does the planning, documents that, the incident action plan, and also collects documentation of the response for the record. And next, that all working with operations and under incident command then leads to logistics. They're there to get us space, staff, and stuff. That's a familiar term to you, as you've heard in our emergency management discussions. But that falls to logistics to identify those things that are needed for operations to carry out the plan. And lastly, it's finance section. They're collecting costs, paying bills, and seeking reimbursement. The key thing to remember about all those boxes that essentially in every response, the roles or responsibilities that fall within those need to be carried out in every response. The key thing for the incident commander is to identify when it's time to start handing out, as I refer to as hats, or assigning people to boxes to fulfill those roles. Next slide, please. So let's talk a little bit more about that medical technical specialist. They're there to be a subject matter expert to the incident command, maybe also assigned to operations or planning, and they're there to advise and oversee the specific hospital operations. So during the pandemic, during other outbreaks, you might have your infection control or infectious disease doc that fills that role because they're consulting specific to that incident, or it's a hazmat incident. There may be some situations where legal or ethics needs to be consulted in terms of the response, or even an administration role person, executive leader that may sit in that. And because there may be those times when they're going to need to communicate with higher, within the healthcare system for freeing up our resources. Next slide, please. So as I said, there's the incident, this pediatric medical specialist could report to the incident commander, or in the planning section in helping to develop the plan. Or lastly, go ahead and click one more time, please. I'm not sure why there we go. Is within the operations section and would but either to the operations section chief or specifically to, again, if that box has been assigned the medical care branch. So a specialized pediatric specialist has been identified in some of the literature. So let me speak to those specific duties. Next slide, please. So again, the pediatric medical technical specialist there to assist in identifying pediatric needs in the emergency response, providing recommendations and advice on the response plan, and facilitate matching of pediatric patients to the appropriate resources, whether that be staff, stuff, or spaces. The American College of Chest Physicians in a 2014 publication identified a specific specialist they refer to as the critical care team leader, who reports directly to operations. So and the significant difference here is if they're reporting to the incident command, the technical specialist would be in the incident command center. But in this case, this critical care team leader is typically going to be, as I refer to it, down in the trenches, working with the staff in the actual response in the care of pediatric patients. So categorizing ICU patients, those that are more critical, and again, setting priorities and communicating those resource and need requirements. Next slide, please. So one thing I did want to highlight while we're here is that the work of RAPM, we produced, and I'm going to put a link in the chat, a pediatric hospital evacuation guide for pediatric patients. And it's there that we do delve into the hospital incident command and the role of the pediatric medical technical specialist. And there's a little bit more information there. I know that's not the topic for this DRC session, but again, there's some good references there, both in helping you plan your evacuation and also just general information for hospital incident command related to pediatric specialists. Next slide. With that, I'll pass it back over to Dr. Kasny for his perspective.
Thanks, David. That was a great overview of HICS and how, functionally it should be working in a hospital system. Next slide. I'm going to really just speak specifically to what my experience has been like through a number of events. And I just wanted to highlight here, this is a picture of our incident command during Hurricane Harvey. And you can see, obviously, more folks than boxes were on David's slide. And this, I think, highlights a point that I like to make, which is while HICS is terrific, individual institutions tend to have a way of tailoring it sometimes inappropriately or appropriately to fit another thing that C-suite and leaders at hospitals love, which are org charts. And so while our org chart for incident command follows many of the major buckets that David outlined in his talk, there are oftentimes some differences here. And what I also want to highlight specifically to this picture, and another reason why I love this picture, is before coming back to Texas Children's and before kind of assuming a role within emergency management as a physician leader for emergency management here, you would see no physicians in this room. So I would say there historically was very limited, if any, physician involvement in incident command. And here you can see a kind of long line of white coats on that left side of the wall there, really highlighting the number of different clinical service lines that we have in departments within our healthcare system. I'm going to speak specifically to where physicians are engaged in incident command and HICS for when we do a full level system implementation of incident command. So this would be for events that we anticipate will impact all of our facilities and all of our regions, so things like hurricanes, winter storms. We do a much more smaller, more nimble incident command when we have one-off incidents at specific locations that really fits probably more the model of what David's incident HICS structure looks like for a specific facility. But those physician representatives or technical specialists can sit in a number of different places. And primarily, I would say my role as medical director is sitting in incident command as that sort of overarching technical specialist for disaster preparedness and response. But as David mentioned, there are often times when other individuals that are physicians get roped in or brought into that incident command structure. Most notably, what comes to mind is, as David mentioned, our infection control physician leadership during things like the pandemic or the triple-demic, when you're having discussions about PPE, et cetera. When we have concerns for radiation exposure incident, we have our hematology oncology member that works with the Radiation Injury Treatment Network that serves as a medical technical specialist, along with myself. Legal and ethics, we have our chair of our clinical ethics committee sit in if we think we're going to be needing to do anything like implementing crisis standards of care. So there's a variety of roles that physicians could play in this room and in some of the subcommands beyond. We try to, like many children's hospitals, routinely operate with a structure of a dyad or triad of administrative leadership, nursing leadership, and physician leadership. And as such, in addition, given the size and scope of our system, have physicians positioned within many of the subcommands. The most notable one is operations, which, as David mentioned, is where a kind of bulk of the clinical operations work happens during incidents. And those folks look like folks that have established leadership positions or medical directorship positions within different areas, such as critical care, pediatric hospital medicine, surgery, and anesthesia, from a clinical ops perspective. When it comes time to look at kind of the bizarreness for which our org chart has kind of overlaid on HICS, I think the most notable change and oddity that we have is when we look at our planning section. That's where we put all of our ambulatory or outpatient things are positioned. Largely when we're dealing with these sort of events, majority of those things are shut down. And we cancel outpatient clinics and elective procedures, but we do have a position that sits in the planning committee to provide oversight, primarily from a recovery perspective, on how we're going to do catch up related to missed appointments, missed elective procedures, et cetera. In that operations piece, we have those physicians that I was mentioning, and that's largely just because due to the size and scope of the operation, sometimes it's challenging to make sure you're thinking of all of the different eventualities related to the disaster response. In addition, because we have 4 freestanding children's hospitals and a large network of outpatient, those individual entities have their own small box on our HICS structure, where they essentially replicate the overarching HICS structure for each of them. And the other physicians present in those would be our chief medical officers for our community sites. So it definitely can build quickly, and ideally you've got involvement and engagement from a variety of physicians that have different backgrounds, training, and knowledge and expertise regarding the system initiatives and work that the system does, playing key roles in many aspects of the response. And again, this is the big picture when we have all things activated and all our subcommands activated for these large scale events. And I think has been a great benefit because it's very hard to be in 2 places at one time. It's hard to be, initially this was me bouncing between incident command and operations subcommand, and now having those physician leaders positioned in those areas. They work very closely with the nursing and administrative colleagues that are in addition in charge of those areas to ensure that we're doing the right thing for the patient every step of the way through these events. Another add that is a tip that we've learned from many of our colleagues who have dealt with things like cybersecurity incidents is the inclusion of a quality and safety officer in incident command that serves a different role than, say, necessarily the safety officer in HICS, but is really ensuring that we're continuing to practice at the highest level that we can regarding patient safety and quality of care. So that was a really quick rapid fire overview, but I'm happy to answer any questions as we move through the rest of the talk.
And we
So,
have
Brent,
some
there's a
questions that are coming
question
into
in
chat.
Yeah, so Anna, we do when we do full scale system level activations, these routinely start with our administrator on call serving as incident commander. Oftentimes and sometimes this can be transitioned to somebody that has more experience as incident commander. If you look at our system, our administrators on call only take that's a week long on call for those administrators on call, and they only do that less than once a year. So we actually do specific training for our AOCs on emergency management that highlights, many of the ICS courses, but does it in a truncated fashion and more rapid fire fashion, just because it's, as you can imagine, it's hard to get these 60 plus administrators to do anything, let alone participate in this AOC training that we do.
I would just add to that. I realized that there's of course, the variation in administration of hospitals and healthcare systems. Some of the hospitals I've worked with, the ones I did work at, I actually started training the HICS with the house supervisor or manager, those that are going to be there at 2 o'clock in the morning on Sunday, so that they could activate the incident command system early on, not wait necessarily for the AOC to respond or But they needed to assume command, whether again, it's the flood in the basement or the mass casualty reception. But and because it's much easier to go stop incident command if you want than to get it started late. So I encourage that
Yeah.
your initial leaders that are always there to.
Yeah, David, it's a great point. Prior to the pandemic, we actually did emergency management training for everybody, director level and above in administration. And that was like a 3-hour course that we put on for them, highlighting things like HICS in addition to kind of outlining the services that emergency management provided beyond that. And it was, I think, a great course, but again, really challenging to get folks to kind of participate in an ongoing place. But we've had a fair amount of turnover in administration here, and it's something that we've talked about revisiting and bringing back.
I think the only other comment I'd make is, well, we've talked quite a bit about medical side. Is there, of course, those leaders, whether it's materials and supply or infrastructure, that also need those same trainings because they're going to fulfill some of those other key roles in the incident command system.
Yeah, the other benefit that I saw of doing it in the hospital, Brenton, maybe you could speak to this for us, is that, the people that are be working together get to kind of learn it and practice it together.
Yeah, I mean, one thing that I think has been a detriment to our responses is this aim towards doing everything virtually that the pandemic brought to us. And there's really nothing like actually having folks in the room having these discussions. And we've had some kind of, misses some during responses post pandemic as we've tried to do this all virtually. Now we do a rapid fire incident command activation through our emergency notification system that links to a Teams call so everyone can get on immediately, but that routinely transitions to what you're seeing on this picture here, which is our in-person command with the sub-commands looking very similar with multiple computers, whiteboards, TVs with maps of the news and what's going on in the region. So the physical presence, I think, can't be understated. It's much harder to have some of the conversations that you need to have and make some of the decisions that you need to have in a virtual environment. During COVID, we had multiple kind of iterations of incident command. And that was really just because of the long-standing nature of the pandemic. Like, you can't keep this up for 6 months. And so we did sprints where we had really targeted goals for incident command. The one that always comes to mind to me is our reopen and redesign command, which was looking at how to make things as touchless as possible, limit any potential exposures, make people feel comfortable coming back to Texas Children's, doing testing prior to elective procedures, things of that nature. And, there were decisions made in that incident command that would have taken 6 to 18 months for the system to make. And we made it in like 5 minutes. Things like adding access to my chart for all, things like that. When you have all the leaders in the room that can make decisions very quickly, and then all the people there that will implement those decisions very quickly, it really, I think, highlights the way that this system can work and be effective in responding and mitigating to issues that arise.
Let me just add to that in terms of practicing hospital incident command is don't wait for the disaster to happen. In my years, we did a movement of pediatric patients as they closed pediatrics in one of my hospitals and moved into the newer one. We stood up incident command. It wasn't just simply, putting them in ambulances and send them over. And the great thing about it was we documented it as an evacuation exercise at one hospital and a patient reception at the other. But I also had the experience of at one of our hospitals, somebody had a brainchild to run a car show in our parking lot. And I said, well, that'd be great, but again, could potentially impact the hospital. So we stood up incident command to run the car show in the parking lot so as to keep things not going awry and not impact the hospital's operation. and use it in many other cases for opening of new wings and those kinds of things, or conversions from computer systems. So the more you practice it, the better you'll be at it when the emergencies do arise.
And then I'm going to address your question in the chat. I think one thing that is, obviously I'm speaking specifically to a children's hospital and children's healthcare system that's really primarily and singularly focused on pediatric care, although we do have adult services as well. I think kind of I can speak to the flip of it, right? So the neglected population or kind of population that we oftentimes forget about are our pavilion for women patients, our high risk OB patients, and our adult patients that we see in that setting. And having representation from that group present is extremely helpful. And so again, it would just be on the flip side if you're looking at an adult-centric hospital system that has pediatrics as well, is ensuring at the very least that in incident command and likely in operations subcommand, there's representation that's the voice of pediatrics in that setting.
Any additional questions for David and Dr. Kasny? Thank you both. Really appreciate the kind of examples that you gave and the background and the kind of in real life experience. And feel free to continue to put questions in the chat. Next slide. No, next slide. Okay, we're going to try to do a couple of poll questions. We've been having a little bit of issues, so if it doesn't work, we'll switch over to a different, to our Zoom platform. But let's try our first question, which is, does your hospital use hospital incident command structure for a disaster response? And I think there's 3 options that you should see there. Yes, we use hospital incident command systems. No, but we use another system, or no, we do not use a incident command system.
Dr. Hussein, I went ahead and launched the poll in Zoom. So if everybody could use the Zoom poll that should have popped up instead of the poll everywhere, that hates me. Thank you.
We have most people responding, and it looks like almost unanimously we have the incident command system that's used. Would love if you have responded that you don't use the FEMA hospital incident command system. What you do use, if you don't mind putting that in the comments, would love to hear what that is. Go to the next slide. Do you have a role in your hospital incident command structure, or what other structure that you use? And yes, you do, and you know what your role is. Yes, I think so, but not sure what your role is. No, I don't have a role, or I don't know if I have a role. And we don't use any standardized incident command system. Very impressed by this group. Julie, for some reason, not all of it is showing up on the...
So we're one step closer. Poll Everywhere is working, but it doesn't seem to be displaying properly. So that's why we've launched the Zoom poll. So I think we've got people
Responding to
answering in
both.
both, which is
Got it.
fine.
Yeah. So we have that on the Zoom, we have that 63% say that yes, and they know what their role is, which is similar to what you're seeing on the poll on your screen. There are a couple who are in the structure and don't know what their role is. There are actually a good handful, or not more, who don't have a role. And then just a couple who don't know, which is valid. Okay, next slide. And then, so I know, like we were discussing just previously, are staff educated at your hospital in incident command? And yes, they're educated regularly, and that's up to you how regularly that might be, or we know that they're educated once at least. Don't know, and not yet, but the plan is to get there. Staff, the staff that you think are most important to the incident command structure that you have. So people that are incident commanders that have a significant role. And again, an amazing group as answers are still coming in. People are actually educated pretty regularly, if not at least once. And knowing how the incident command, the FEMA IS courses, those are long. So to get people who have staff doing those at their hospital, kudos to actually getting it done, because that's a lot of time that people are putting in. There is only a couple that have not yet, and a couple who, a little bit more than a couple who don't know. So looks like people are at least getting the education at least once. Okay. And then there's some nice discussions happening in the chat too that I'm gonna let you read, and we can come back to if anyone has more questions. Okay, next slide. Okay, want to make sure that we have enough time for our breakout sessions. So we're going to divide up, just have, these are questions that we're going to be going over, but please feel free to discuss whatever you'd like about incident command systems and structures at your hospital within your breakout session. It is storming where I'm at, so if I cut out, I apologize. I think so far so good though. We are going to go through a quick round. We have 5 breakout sessions, and we'll go through and have our facilitators or a spokesperson call out from each breakout session just a couple of points on things that we heard that might be great for the larger group to learn from. Can I go with breakout group 1? And if you don't know, if you just want to start speaking, then we can figure it out. If you don't know what breakout room you were in.
I think that was Dr. Lazon, and that means that I need to unmute her.
Thank you. I forgot which breakout room I was in. I was really focused on both barriers and wins in our group. And one of our colleagues talked about the barrier of having people stay in their lane in the incident command structure, understand what their role is, and not go into a silo and do stuff outside of and forgetting to tell the incident commander or the command staff what they're doing. That's such great advice. I'm going to betray my tribe and say that doctors, especially physician leaders, are very good at running into incident command and starting to try to run stuff that they don't know about. And so, Dr. Hill, thyself. The other thing was some wins. I think once you get a critical mass of people trained, and have an ongoing kind of practice structure and ongoing meetings and ongoing emergency management operations culture in your system, standing up incident command becomes not such a big deal. And you can use it for responses. One colleague shared that they stood it up for wildfires in LA and just had quite an excellent in person, in the middle of the night, but had quite an excellent outcome because everybody truly thought outside the box, and they got folks going on projects in response to that incident that they may not have thought of. They activated their mental health team. So and they activated a shelter. And so it sounded really great. And I shared a story about a very, very critical blood shortage in my institution that kind of accidentally came to the attention of us. And we opened up a limited incident command for that and really averted having to either go on diversion or refusing trauma victims in a level 1 center or refusing high risk OB, because we were able to immediately respond to that. And I don't think it could have been done by like just blood bank making a bunch of phone calls. It needed that overarching leadership structure and people having an assigned task and a branch and go off and effectuate and come back. So I think it just speaks to the HIC system. It can be quite effective and nimble if you get your folks acculturated to it in your system.
Thank you. That was all really amazing. And because I forgot as well, am I session 2, Julie? Okay. So we had some amazing discussions, really, really good group. There was some really great comments. One was on how do we get, the full awareness of incident command. And it sounds like in LA, they have something called a DDL that they're putting in place, or have been trying to kind of stretch out, which is department leaders, but also unit leaders that are being educated and kind of like the disaster advocate for their area. We talked a lot about some of the challenges that people face, and part of that is on activation. Again, going back to that one of our earlier sessions, and not the taboo of activating when it might not be needed. Some of the things that we've found that were helpful of that is having a group that gets on a huddle call, so a smaller group that is disaster aware, and they can help make that call for activating the incident command or not. Also having an emergency manager or deputy on that call is really helpful, so people don't feel like they're making it in silos. The other thing that was brought up is, coming in with an incident command, opening up the full incident command and then scaling back, like coming in aggressively, versus the thought of coming in, Marie, like you just had said, is doing like a modified or a limited incident command and then building up as needed. And then that knowing that both of those are possibilities, but I think culturating is a good term to use, culturating to incident command, so it's less of a taboo. Okay. Session or group number 3.
So Dr. Lazone was group 3, so we'll ask Dr. Dahlgrove from group 1.
Yeah, we had a really great discussion. It was just interesting hearing people's different level of experiences. I think one of the highlights I would say is that when you're a bigger hospital that has a pediatric hospital integrated into that, how do you make that how do you successfully integrate that? Because it's something that we've all sort of struggled with, and you sort of continue to struggle with, and how do you, work on that. So we talked about different ways to do that. We talked about a little bit about virtual incident command, which I think was brought up just before we went to the break, and whether or not that's successful or not. How do you scale up, scale down? Do you do a hybrid? All those kinds of things. I think were interesting points. And I think another point is how do you educate both vertically and horizontally within your structure and your system about how big does incident command get? Who do you report to? What's next? When does it get activated? All that kind of stuff. Because, there's the boots on the ground people, and they may not truly understand the whole concept of incident command. How much ICS training do you actually get, and so on and so forth. So I think there's just different ways of sort of approaching the whole thing.
Thank you. And that virtual incident command has also come up, and I'm sure that a lot of hospitals are facing that question now as people are more remote. Group number 4, are we at? Yep. Do we have a group 4 facilitator?
Dr.
Yeah, Mina,
Kat-
I can do
well-
it because Dr. Kasny had to go, so I can let you know I was in group 4.
Thank you.
Yeah, I would say that there were two things that our group talked quite a bit about. One was that Brent off when he was talking with us talked also about a unified command that he has kind of separate from incident command, because we're struggling with kind of how to elevate those bigger organizational decisions that happen and can happen in incident command, but really hospital leadership also wants to know about, especially in today's climate of cost. And so just having to navigate kind of those two worlds when you're trying to make rapid decisions in incident command, but also still have this hospital leadership who is watching things pretty closely right now. So his version of that was a unified command, which I thought was interesting, and going to kind of think about how we've done that, because we've done it kind of unofficially here, but we haven't named it anything or said anything, but it really refers back to, organizational leadership. And then secondly, we all decided that somebody should go into business where you distill down the ICS 100, 200, and 800 courses, like we all freaking do at every one of our hospitals, to make it as brief and concise as possible and distribute out to all of us, because we all do this exact same thing to get people to potentially do the training, since they won't sit through the ICS courses. That doesn't seem to work for any. Nobody reported that works for them, that telling people these are the things you need to do before you can come and be incident command and all that. Nobody said that works at all for anybody and their leadership. So there's obviously business to be done here for somebody, or an excellent resource, since we all are doing the same thing.
It'd be interesting to see if people taking that versus taking another course are able to function better in incident command. Thank you, Bree. And I think 5, is that Anna?
Yep, that's me.
Awesome.
We had a really awesome group. I think a couple of different like models in terms of like a hospital within a hospital, maybe separate but connected with adult facilities, and then just the specific peds. One of the things that hasn't been mentioned before, we had Nathan Tim with us, and so he was telling us about the pediatric fix, the pediatric hospital incident command. I think did I say that right, Nathan? And they basically align their response system and mitigation system into the 6 elements of performance for emergency management, and that was really interesting. We talked also a little bit about how folks communicate, and Nathan was sharing at Cincinnati Children's that they do it with text, and they have a text thread that they start every week. And then using MS Teams, which I think multiple of us use as either a virtual component or as a bridge to physical to physical hospital command system. In terms of training, some of us are using the ICS training. Some of us are using, there's a Kaiser CalOES slide deck that can be used, and then really emphasizing exercises and drills to engage folks in training for their hospital incident management team. Let me, if folks from the group, if I missed anything, I know this is high level overview, please feel free to add to chat, and I think we can move on to the next group.
I think that's everybody, right? Julie, I'm going to hand it off to you because I know we have a couple of minutes left.
Thank you. Thanks, everybody. It sounds like those great breakout sessions, so that's really exciting. So as we close it up, I'd like to give you some PPN and DRC updates. Here's where we are in our DRC checklist. You should be working on the PDPAC, either register or complete the survey. Again, that deadline was May 31st, but we've kept it open. We want to get a lot more responses. We know that it wasn't a very long time for such a long survey, so please, please, please register and complete that survey. That is considered your DRC environmental scan. So it's not just going to give us some amazing information about the nation's disaster preparedness from children's hospitals, but it's also going to serve as your environmental scan for DRC and where you are in your plan. There's also, if you have done your tabletop exercise, you should have received a data collection survey. That is a very short survey. You would have received it from the dnc.ppn@austin.utexas.edu email sometime in the last couple of weeks. But this is going to collect information from your TTX. So whether it was virtual or you've done it in hospital, we want to hear from you. We want to know what you discovered, your ahas, your barriers. We want to hear it all. And then we're going to talk about that in a few months to wrap all of this information together while we're collecting all this data and how you're going to be able to use it to improve your disaster plan. Also wanted to give you an update on where we are on the available virtual tabletop exercise sessions. If you have a second focus area of TICD, triage, infection control, and decontamination, there is a session tomorrow, but I wanted to let you know that their availability, if you still need to do a TTX, there is room June 5th, but that's a really short time turnaround time. So we need to know as soon as possible, and you and your staff need to know as soon as possible. So I know that's pretty short, but it's available if you want it. Also have evacuation on June 12th, and we have a new date for reunification of June 26th, if anybody is interested. Our upcoming DRC sessions, we've got next month, we'll meet here, same time, same place, same group. We're going to meet back with our surge capacity group. So the link will be the same as well. In August, we'll come back as a collaborative. So all 4 focus area groups will meet together, and you can register with that QR code. Registration is also on our website. So in July, we're going to be talking about more about our tabletop exercises. We want to hear from you. So come prepared in July to give us a summary of what you've been doing, any obstacles found, any aha moments. So if you've completed your data collection survey, the short one, then you'll have all those answers right there in that survey. And then in August, I want you to know that you're going to be prepared. We are going to ask one team to do about a 5 to 6 minute presentation on your tabletop exercise. Presentation seems like a much bigger word. Think of it more as a report out. So we're going to ask one team to report out on that larger session. So more to come on that. We want to let you know that there is a PPN legal webinar on the crisis standards of care coming up on Wednesday, June 11th. The QR code down here, I cannot copy and paste that right there. But there's that webinar coming up next Wednesday. There's an ECHO series hosted by PPN on disaster mental health, preparedness and response to catastrophic events. This is an ECHO series. So it's going to be 6 60-minute biweekly sessions. So you'll have the didactics in the beginning, and then you'll have a discussion about a case study towards the end. That's going to be at 12 p.m. Eastern. So notice that Eastern, we usually post things in Central Time. So just be aware that this time is Eastern. Here is your code, FUNJOL, if you are looking for continuing education. You can go to the pedspandemic.org, ce.pedspandemic.org page and put that in, or you can text it to that phone number. So if you need to screenshot or take a picture of this, I'm going to leave that right there for just a second. And then one thing you will need to complete your CEs is the evaluation. So go ahead and take a picture of that. If for whatever reason, and there's lots of reasons, if you can't do the QR code, if it doesn't open for you or whatever, please email me at dnc.ppn@austin.utexas.edu. And I will get that to you. Once you open that, feel free to close your browser and have a wonderful, wonderful day.